Welcome to our webinar on global survey results with respect to the rights of people living with ALS, MND, and their caregivers. For this webinar, we have English and Spanish captions available. If you're joining us live on Zoom, please check the chat box as we're adding the instructions right now. If you're watching the recording later, you will find it in the video description, instructions on how to activate the subtitles. We really want to thank our sponsor, Biogen, without whom these webinars would not be possible. For those of you that don't know us, I'm Catherine Cummings. I'm the Executive Director of the International Alliance of ALS, MND Associations, and I'm joined today by Jessica Mabe, who's our Programs Coordinator. We will also hear from Angelique Vanderleet, who is a member of the Alliance's PALS and CALS Advisory Council, and she was fundamental in development of the survey. For anyone new to this community, we use the short form PALS and CALS, and the short form PALS stands for person living with ALS, and CALS is a short form for a caregiver of a person living with ALS. And I wanted to make sure that we spelled those out because we do use it a number of times throughout the presentation, and it's important, especially for the captions, to make sure that we understand what those terms are used for. Let's hear now from Angelique, who will tell us more about the history of the fundamental rights in which we based the survey.
The first version of fundamental rights was conceived in the 1990s. The PALS and CALS Advisory Council, PCAC, is charged with helping the board of directors of the International Alliance consider and include in its work the wide-ranging opinions and ideas of people with ALS MND and caregivers to the people with ALS MND from across the globe. And the fundamental rights are reviewed and updated annually by the PCAC. In February 2021, an independent document of the fundamental rights for caregivers is created, as their needs and rights differed from those of the person living with ALS, but also of very great importance. Next slide, please. Our aspirational statement is that these fundamental rights represent the ideal for individuals living with ALS MND and caregivers worldwide. These documents represent the set of rights of all Alliance members, organizations should adopt and promote as conditions. Systems and resources allow. The first version of fundamental.
Thank you, Angelique, for recording that history of the PALS and CALS fundamental rights. Before we get started, I want to root the information that you'll be hearing today in the actual fundamental rights documents in case you're not familiar with them. We want to make sure that all of the work that the Alliance does is rooted in these fundamental rights for people living with ALS. And so we thought it was a good idea to use them as a starting point for this particular webinar, as the survey is derived completely from these rights. So the rights of people living with ALS MND, they have the right to the highest quality care, the highest quality treatment, information and education, and most importantly, choice. They also have the right to end-of-life choices, accepting or refusing, and to provide input into their healthcare systems. They also have the right to the best quality of life possible and life without discrimination. They have the right to confidentiality and privacy and economic remuneration where possible. And newly added this year, they have the right to access to genetic counseling and testing at the time of diagnosis, as well as safeguards against genetic discrimination, and subject to education and counseling. Blood relatives should also be given the same access where relevant. As Angelique indicated in her remarks, this year the PALS and CALS Advisory Council separated out the fundamental rights of caregivers of people living with ALS MND, and they have the right to access information and education, to training and resources, to timely appointments and treatments, and also to remuneration. They have the right to support in all areas and to provide input on the healthcare and support systems within their own jurisdictions. So, as I said, the survey was based completely on these fundamental rights, and the key objectives of the survey were to find the strengths and weaknesses at the global level and be able to learn from the best and address ways to help associations and regions to come up to a higher standard. The Alliance is an association of associations, and we wanted to be able to compare and contrast what works in one area against what's happening in another. Another goal of the survey was to provide data from each country with the opportunity to benchmark and evaluate, to generate further questions and raise topics that require further attention and discussion at roundtables or at the annual conference. What are the opportunity gaps that exist around the world? Highlight the areas that the Alliance can prioritize for the creation of resources to help member associations in their advocacy, and provide insight for further focused surveys on specific topics to capture more granular data. We began data collection with a soft launch on Thursday, August 19th last year, and the survey was rolled out fully on Thursday, August 26th. Data collection closed in the morning of Monday, September 27th. So the survey was open for approximately 1 month. The survey was available in 10 languages, and we want to take this opportunity to thank our member associations who took the time to help translate the survey. This was key to capture data from non-English speakers. We received responses from 32 countries, and total responses received 1,086, which break down into 410 or 38% were from people living with ALS, 474 or 44% were from caregivers of people living with ALS, and 202 were disqualified as they responded other to the initial qualifying question. The ratio of qualified responses was as we expected when we went into the survey process. We had an incredible global response, and here you can see the list of 32 countries that participated and those that were represented by one completion. The participation of 9 countries that were more statistically significant is the analysis that we're going to show you today. Normally, the cutoff for showing results is 30. In some cases where the base sizes were smaller, the low 20s were included. To support our analysis, we also marked the significantly statistically countries by socioeconomic status by income using the World Bank knowledge base. The statistically significant countries were both under high income economies and upper middle income economies. The lower economies were not represented in the group of countries that we're going to look at today. We've identified some drawbacks of the survey. We learned some lessons through doing this survey globally through social media and through other avenues, and we'll take them into account in future surveys. We did have an unbalanced number of responses by country, as you probably noticed when we went on that slide. And that's partially because we didn't have a very long runway between deciding to do the survey and launching it. So communication could have been better. Accuracy on the formulation of some questions also came to light, and you'll see this as Jessica analyzes the data today. She'll point out one of the questions in particular where we used more than one option within the root of the question, and that causes some inaccuracy in terms of the data collected because we're not sure which part of the question people were responding to. One of the things I want to say before we launch into the data is that in many cases, we're going to focus on the opportunity gap and, you know, where the Alliance and its members should focus in the future. But we also have to remember that we've come a long way on our aspirational goals, and there's a lot to be proud of globally as well. So what really stood out for us on the survey was access to multidisciplinary care, to clinical trials, to treatments. And this is going to be something that is going to be a longstanding issue for the Alliance. We see it, we see the access issues globally, between country to country. We see it regionally, and even sometimes within countries. Like my own, I come from Canada. We have different access depending on the various provincial healthcare systems. So for us, the access issue really stood out. The other thing that really jumped out at us from the surveys was that caregivers feel they have no voice, and Jess will explain that using the data as well. But we all know from you know, other anecdotal evidence, especially during the pandemic, that the burden of caregivers has increased, it feels like almost exponentially over the last couple of years. And we really found from the surveys that caregivers felt they had no voice. A third important finding for both caregivers and people living with ALS MND is that remuneration is not always available to support them on their journey through ALS MND. And the last piece that really jumped out at us was that genetic counseling and testing is not universally available. It's a relatively new area and by new, I mean, you know, the last 10 years or so. And it's certainly not universally available to all of our community at this point. So I'm going to pass the slides over to Jessica now so she can look at the data, and I'll jump back on at the end to sum things up. Thanks very much.
Thanks, Kathy. So the data we will be sharing is focused on the global responses from statistically significant countries, as Kathy already mentioned. In this chart, we have summarized the agreement responses for the fundamental rights of PALS. The bars colored in purple and orange is to identify the rights that had various components. For example, the purple bars refer to the right of choice with respect to various areas. The first piece of data that stands out is that the overall agreement is under 75% and the median is 45%. Healthcare and treatment have 49 and 44% agreement respectively. Very low considering they are the key pillars on the quality of life of PALS. We have a massive challenge to overcome around accessibility to treatments. 59% agreed that they had access to information and education. We're not surprised by this figure. We are aware language barriers are a key factor, with most of the information being published in English. The partaking in choices, our purple bars, are around health and support workers, treatments, and places of care. This is under 50%. The right to accept, refuse, or discontinue treatment is the second highest in agreement with 67%. But further surveying is required to understand which is being respected, the right to accept or the right to refuse. The right to provide input on healthcare and support systems is very low with 35% agreement. PALS are the ones that know what they are going through. What can we do so their experience is considered? 49% agreed that they lived without discrimination. This data requires further surveying. Discrimination varies and the perception is different. The level of discrimination varies in countries and regions and races. The survey did not specifically address disability rights, and we are aware that these are not being respected in many parts of the world. Right to confidentiality and privacy is high with 75%, but this data raises the question if the respondents consider near aspects of confidentiality like in genetic testing. The right to remuneration, benefit, and entitlements is very low at 40%. 25% agree to have supplemental insurance. Why is this so low when this could help PALs and their families from going into poverty, and it would help covering many of the costs that ALS MND diagnosis incurs? Last but not least, our orange bars refer to the fundamental rights focused on genetics. Overall, the agreement is very low, ranging between 45% and 24%. Genetic counseling and testing are fairly new areas and still not implemented in many parts of the world. There is still a big piece of educating that testing needs to go alongside counseling. So let's start with the definition of access. The Cambridge Dictionary defines it as the right or opportunity to use or receive something. Here we see the responses for agreement to having access to highest quality healthcare. Global responses was a 49% agreement, and the graphic shows the contrast in responses between high-income economies and upper-middle-income economies. At a global level, the survey allowed to extrapolate the drivers of highest quality of care in the following categories: receiving care from a social worker and nurse who specializes in ALS MND and an occupational therapist, also having access to a multidisciplinary clinic, and receiving support in voice banking at or near diagnosis. This graphic shows the responses to having access to a multidisciplinary clinic. Only 46% have access to a multidisciplinary clinic. Concerning figures, but not surprising. Factors to consider for these responses are access, for example, travel distance, cost, and knowledge. Let's look in more detail at the global responses. Please note this graph shows those that answered no and unsure. Straight away, we can see that in the upper middle income economies, they do not seem to have access to a multidisciplinary clinic. At a global level, 54% answered no or unsure. What can we learn from the countries like Canada, the United States, and the Netherlands to start improving access? This graph shows how PALs responded when asked to select the professionals they receive care from. It is concerning to see how it declines from neurologists, with genetic counselor only at 7%. We have the same issue as with the multidisciplinary clinic. How can we ensure access to a multidisciplinary team and that it becomes standard for all PALs? Let's look now at the responses for access to a neurologist. What can we do so that globally we show a result like the United States? Clearly, high-income economies lead here. What needs to happen so that all PALs receive care from a neurologist that specializes in ALS MND? Let's now look at the global responses for receiving care from a genetic counselor. High-income economies lead here, but 22% is the highest figure and drastically dropping, with many countries not having access to a genetic counselor. At a global level, only 7% confirm to have access. What needs to happen to incorporate the genetic counselor as a standard in care? We also want to highlight the relationship of having access to an ALS MND association that provides care and support. 70% said yes to having access to an association, 21% said no, and 10% were unsure. It is important to highlight that not all associations focus on providing care. Some, for example, focus on research. We also need to take into account that not all countries have associations and not everyone knows the benefit of connecting with their local association. Now, let's move on to access to highest quality treatments. This figure reflects agreement on having access to highest quality treatments available within the healthcare system. There is a 53% disagreement in having access to treatment. Now let's see how this is reflected with our statistically significant countries. This graphic shows the levels of agreement. We have a strong contrast between the high income economies starting at 81% and the upper middle income economies going as low as 9%. What should be the minimum a PALS should receive in treatment? What is the standard we should aim to have? Okay. Now, this graphic reflects what PALS selected as having access to a treatment. We have Riluzole at the top with 75%, so not all PALS are getting Riluzole. And then the figures drop drastically. Being willing to participate in clinical trials, 38%, having no access to clinical trials, 36%, access to edaravone, 26%, having participated in a clinical trial in the past is 10%, and having access to clinical trial but not participating, 9%, and currently participating in clinical trials, 7%. Except for the Riluzole, all these other treatments have very low agreement responses. So now let's drill further into this data. Only 75% have access to Riluzole. So let's see what the surveyed countries tell us. We keep mentioning access, and this graphic shows so clearly the global imbalance and how countries responded to no and unsure. We have Peru with 100% respondents answering that they have no access to Riluzole. Out of the global responses, 25% said no or unsure, and then we have the Netherlands, the United States, and Canada with the grand majority respondents confirming they do have access. We need to learn more about what is happening at both ends of the scale and see how we can help improve access for those countries that need it. We can tell you now that the Alliance has already started doing some work based on this data, and we will be working with the member associations to see how we can help improve access in their region. The data on edaravone tells a different story. Only 26% have access to edaravone, with the highest access in Canada, the United States, and Japan. In this image, we show the responses for no and unsure. Once again, the contrast goes from countries having access to no access. What are the limitations on access in these countries at the top of the graph? Between us, can we find common denominators to try and find a solution? Let's look now at the data on clinical trials. There is a willingness from PALS to participate in clinical trials, but access to them is one of the biggest challenges. Geography and information on how to participate seems to be the main obstacle. At a global level, we can now extrapolate that the top 3 categories on drivers for highest quality treatments are having access to clinical trials, to have participated in a clinical trial in the past, or that they are currently participating in a clinical trial. So let's now talk about genetics. We have put these 2 graphs together because we want to always talk about genetic counseling and testing together. We can clearly see the countries that are leading in the offering of these services. But at the same time, the disparity is very large when we go to the countries at the bottom of the graph. Looking again at this image, only 7% of our respondents confirmed that they receive care from a genetic counselor. What can we learn from the countries that are leading in access to this professional? How can we transfer this field to other regions, and how can we ensure genetic counseling is always done before genetic testing? Okay, so now let's talk a little bit about caregivers. This image reflects the fundamental rights for caregivers. What jumped at us was the very low agreement numbers. Overall, agreement was under 61% with a median of 30. Note how much lower this is to PALS, who had a median of 45. Regardless of where you are in the world, caregivers feel very unsupported. Our orange bars represent the right to have access to information and education, to training and resources, to timely appointments and treatments. Our next bar refers to remuneration. 27% agreed that they received some type of remuneration or entitlement. sorry, our purple bars represent support in all areas that include counseling, emotional support, respite, time for themselves, palliative, and bereavement support. Notice how low they are, an average level agreement of 26%. And our blue bars represent the right to provide input with 33 and 32% agreement. As you can see now in this image, all very low agreement figures. We've got counseling at 37%, palliative care and bereavement advice, 28%, emotional support programs, 27%, time for themselves, 23%, social or respite support, 22%, and the ability to plan for their future, 20%. Overall, we can see caregivers are feeling very unsupported. We need to consider that CAL's well-being has a direct effect on the PAL's quality of life. What can we do to improve in all these areas? Now, this chart reflects the level of disagreement from CALs being able to provide input. 60% of CALs disagree in being able to provide input on the healthcare and support system, including policy making and care delivery. It stands out that CALs are feeling without a voice. At a point in the ALS MND journey, the caregiver becomes the person that has to navigate the healthcare system, who liaises with the multidisciplinary team, who knows the treatments, those doses, the protocols the PALS is taking, and what effect this have on both of them. PALs, in their own way, are expert in these areas. How can we help caregivers so that they share their experiences, so their input is also considered? Now, this is the country breakdown. Even at the high end of the graph, we're looking at only 50% agreement. How can we give caregivers more of a voice? Now let's move on to remuneration. Remuneration is a hot topic. 53% of PALs disagreed that they received remuneration, benefits, and entitlements to assist with the provision of care. In some cases, there might be some benefits, but PALs are unaware of them. How can we help PALs be informed of what they can get? And can associations do more on the informative angle, especially on what is available in their country? Here we see how the countries responded. Japan leads with 96% agreement, followed by Canada, the Netherlands, and the United States. Globally, there was 40% agreement. What can we learn from the countries that are successfully helping PALs with economic remuneration, benefits, and entitlements that assist with the provision of care? Now, this graph shows 69% strongly disagreed to the statement of receiving remuneration, benefits, and entitlements to assist on the provision of care. Caregivers sometimes have to stop working, resulting in additional financial burden and stress. Any type of remuneration, benefit, or entitlement can help to cover ALS and MND costs. How can we help CALs be informed of what they can get? Here in this graph, we see that Japan also leads in remuneration for CALs with 65% agreement, followed by the Netherlands and Canada. We do think that a more detailed landscape is required to understand where CALs are being remunerated, and also let's learn from what is working and how it was achieved. This chart reflects the answers on supplemental insurance. 63% said they had no access to supplemental insurance. Anecdotally, we know that ALS is a disease that causes poverty, but supplemental insurance can also be very expensive. We can see here the country breakdown on the responses for not having supplemental insurance. We can see the high income economies at the bottom of the graph. Can we learn from the countries that rated low? We also need to consider how the assistance is provided, as the survey question was not clear in the method of remuneration. It doesn't need to be in currency, but could also be by the offering of services. So I will now let Kathy tell you about the top issues we found and the Alliance's next steps. Thank you.
Thank you very much, Jessica. I really appreciate you taking us on a tour of the data and digging deeper into each of these issues. Having gone through the data, we've identified some top issues. I did speak about these a little bit at the beginning, but I just want to reiterate what we found. And for us, for sure, the piece that jumped out very significantly is that access is a global challenge. High income and low income countries are all affected. And we want to make sure to aspire to our fundamental right that individuals living with ALS MND have access to a multidisciplinary clinic, which is currently not the standard everywhere. This is the area that made me make my remarks at the beginning of the webinar, which is to say that the Alliance is 30 years old. We've come a long way in those 30 years. And we know from other resources and other research that multidisciplinary care should be the standard of care for everyone. And we know from this survey that it is not the standard of care everywhere. And we'd like to continue to move the bar on that. But we have to thank those that have worked hard on this for the last 30 years to make it the standard of care in many areas around the world. So we have to see both the positive and the negative, I think, in this particular issue. Access to clinical trials is limited in many countries, and we need to delve deeper into that. Treatments are not universally available, as Jessica stated when she looked at the data with riluzole and edaravone. Genetics counseling and testing is not accessible worldwide. This is a big one for us as the results were so low. It is an area that the International Alliance is really focused on changing the landscape going forward to ensure that genetic counseling and testing are available at the time of diagnosis. And remuneration is really key to alleviate the financial strain for PALs and CALs. We all who have been in this community for a while have anecdotal evidence of individuals and families who've been put under great financial strain from being diagnosed with ALS MND. And so this is an area that we want to look into quite a bit further. And the other top issue that we've mentioned throughout is caregivers don't feel supported and they don't feel that they have a voice. So what is it that we can do to help support caregivers globally and to make the journey a little easier for the caregiver community? So what are the next steps that the Alliance is going to undertake from this data? As you can imagine, it has created quite a long laundry list of things that we might be able to do. We, of course, have limited resources and can't do everything, but we will dig deeper into the data. And we'll discuss the data with those countries that had enough respondents to make them statistically significant. So we'll compare those countries against the global figures and see what opportunities might be available for them locally for improvements and what they want to focus on. We'll also look at doing further surveys. We consider this survey a baseline of how we're doing with respect to the fundamental rights for people living with ALS MND and their caregivers. And if we do a similar survey a year down the road, 2 years down the road, even 5 years down the road, we'll be able to see if the bar has moved towards our aspirational goals and whether or not we've made strides in terms of access for any one of the areas that we've mentioned. We'll also learn from the strengths identified and improve in the weak areas. We'll identify the areas that the Alliance needs to prioritize. We are about to embark on strategic planning, which we do about every 3 years or so. We are having a strategic planning meeting in May, and this survey will provide us with a lot of data to be able to identify those areas that we need to prioritize. As I said a moment ago, we can't do it all. We're a small resource organization, but we certainly have our work cut out for us from this data. And we'll work with our member associations on how to address the access issues that were identified. So those are our next steps. And before we head off, I want to see if there are any questions in the chat boxes. I want to thank you for your time. And I want to take this opportunity to invite you to subscribe to our newsletter and to join our next webinar, the first in our care series, What Do I Need to Know at Diagnosis? And Jess, I will turn it back to you to see if there are any questions that have arisen. I know there was one question in the chat before I came back on to speak about whether we would issue a certificate of attendance. It wasn't something we had anticipated doing, but we're certainly happy to do so. So feel free to reach out to us at Alliance, ALLIANCE at als-mnd.org, and we can help out with that. So I did see that question in the chat before I came back on. Are there any other questions that we need to address?
Yes, Kathy, we have a few more on the Q&A box. So they said, what tools or laws do I have to access treatments such as Neuron?
I don't believe that treatment is approved anywhere. I'm not a scientific individual, so I can't answer questions about specific treatments, but you're welcome to reach out and ask that question individually and at the same email address that I just gave, and we'll direct you to the appropriate individuals. I do want to mention one more thing around the remuneration piece that I meant to say, that our Pals and Cows Advisory Council has had on its project list for a couple of years now to do a deeper dive into an economic indice of how remuneration is handled in different jurisdictions around the world. And so we've just applied to a healthcare organization to get some help with this, to be able to create this indice to, hopefully be able to benchmark certain countries against others to see how we can improve the remuneration landscape around the world. So I meant to mention that when I was talking about remuneration, that's one of the projects that we've just recently taken on to try and move forward on our agenda.
Kathy, we're also getting quite a few more questions about how they can have access to data by country.
We will be publishing a report out of this webinar that will indicate the data that we have. In the countries that we had low responses in, it's not statistically significant enough to be able to draw any conclusions from. So we will be including the countries that we looked at today.
Yeah, I'm just scrolling very quickly to see if we missed anything. Bear with me. I think, know a lot about the material. I think over the next few days, we will release the recording of this webinar on our YouTube channel. So all the data will be available to watch again, if that's what you want to do. And I think that's all we have on questions that I see here, Kathy. Not sure if there's anything else we want to add.
Excellent. I see that Alper Kea has noted that Turkey has received good news since the survey was completed. So I hope that means that some of the access bars are moving forward within their jurisdiction. And we appreciate you putting that comment in the chat, Alper. Thank you.
Okay.
Have a great day, everyone, and thank you for your participation today. And if you have further questions, feel free to email us at alliance@als-mnd.org, and we will answer your questions through email. Thanks very much.
Thank you. Bye.